ooh, I want to be a commander one day? No? No, not at all. The exact opposite, right? All right, let me kill some lights with some mood lighting here first, all right? So this is pretty much what our class is going to look like for the test as well, all right? I am major passion, okay, teaching radiology. A little bit of background on myself before we get started. Came through this exact same program. So I was originally a rad tech when I joined the Air Force. So I was enlisted for 8 years doing this exact thing, X-rays, CTs, that kind of stuff. And then put in for IPAP, got picked up for IPAP, so came here, sat in your seat for all 4 semesters, so good choice. And went through this exact same program, right? So I feel you, I understand the stressors, I know what you guys are going through, like I get it. So I will try to make this as painless as possible. But no, I came here, came to this program. After I graduated, I went to Edwards Air Force Base, California. I don't know if anybody knows where that's at, middle of Mojave Desert, middle of nowhere, small little rinky-dink place, right? Where I was grateful for courses like this because we didn't have a radiologist on staff, right? So it would take a day or two sometimes to get the reports back. Well, if I got a soldier or an airman coming in to see me, and I need to know is something broken, I don't want to wait 6 to 8 hours before I put them in the appropriate boot, get them whatever referral they need, right? I'd have to look at it myself. So some of you may be at places like that to where you don't have a radiologist on staff and you're going to have to wait, right? And that's where this kind of stuff comes into play. I did about 4 years there, both active duty medicine and beneficiary, and then PCS to Luke Air Force Base in Phoenix, Arizona. Did some time there as, again, a beneficiary and WAMC or active duty medicine PA. Deployed, and I say that because it wasn't deployment, but it was an overseas deployment, to Holloman for about 6 months, really like 4 months, 4 to 6 months. During that Operation Allies Welcome, when all that stuff went down in Afghanistan and we cleared out, and they brought over those 100,000 plus refugees, right? I was at one of those safe havens, so like meeting them as they got off the plane, taking care of any medical needs they may need because they didn't have care when they were over in Afghanistan, processing them through immigrations, immunizations, wait for it, reading chest x-rays to check for tuberculosis because we had one radiologist who can't work 7 days a week, 24 hours a day, right? Did all that, went back to Luke, and then was flight command, or I think battalion command would be similar to the Army, for about 40 people there for a while, before I got picked up for the education fellowship and came here, right? So seen quite a bit of stuff, practiced on both sides of active duty and beneficiary medicine in a family practice setting. So happy to answer any questions you have about that as we go forward. Some of you will see me again in junior or senior semester for ClinCorp when you get there in the small group stuff. But that's just a little bit about me. Radiology and some housekeeping items, right? I know the reputation this course has. Right? I knew it before I even took it over. We're making it better kind of in that aspect. It is abstract, right? I'm not gonna lie. It is difficult to kind of wrap your mind around a little bit because what you're trying to do is look at pictures that you've never really looked at before and find abnormalities, right? That can be challenging. We're gonna break it down step by step, okay? This is a course that, again, remember, I sat in your chairs. I remember studying other stuff when instructors were up here lecturing on a different topic because that test was coming up. So I'm really glad you have no test on Thursday. It means I have at least 70% attention. But this is a course that it would really behoove you, at least during lecture time, to focus in on this because there's a lot of pictures, right? I'm going to try to show you a lot of things either by drawing or using my laser pointer to help you see what I see as we're going through stuff. The challenge with that is if you're zoned in to say farm, which luckily that's done, so I can use that, or Clim Lab or ENT, while I'm pointing out stuff on pictures, when you go back to look at it over the weekend before the test, you missed what I pointed out. So you're missing what I tried to show you potentially because I don't have a way to do that. Some things are circled in arrow signs, some things aren't, right? There are slides with words that break stuff down, but that will just help you do this course a little bit better if you're kind of tuned in on that. And that's what makes this one so difficult, right? Also, this is one of the first ones. I think you've done some pathology where we'll start getting to some patient vignettes, right? You start giving you some signs and symptoms to help you get to most likely, and then you use the picture as adjunct right? Very rarely am I ever going to slap an x-ray at you, even on the exam, and just say, what's wrong, right? Unless it's a describe this fracture, which you will get to, and you got to look at the angle, right? But if I'm trying to make you make a diagnosis in this block, which is mostly MSK, right, of a type of fracture, or something with a kid or something like that, I'm going to give you those symptoms to help you get to that diagnosis, right, where the picture is in addition to, okay? Block 2, chest and abdomen, a lot of stuff looks the same, so those symptoms really play a role into what's going on. What else? Housekeeping stuff. Testing. There are a lot of pictures on my test, okay? If you currently use the app to test, please start testing out some type of web browser. The app does not work well with my exams because it crashes. I think you guys saw that. I know that was the junior class, saw that was the ortho test. If you use an Apple product, try Safari. In one of your exams coming up, please try using the web browser to make sure you know how it works and that it works well and things are going okay, because for my exam, you've got to use the web browser, okay? The app will not work. In that aspect, there will be pictures. There will be at least one question, could be more than one, at least one question where the answer is going to be normal x-ray. Right? I'm not trying to trick you, but the majority of what you're going to see when you're out in clinic and you order these imagings is probably what? Normal. So you've got to know what normal is. You've got to be able to pull out normal and not make up phantom diagnoses just because somebody's injured. So there will be at least one normal x-ray. What do questions look like? Some first order stuff, right, with a picture. Some questions without a picture, especially in this block, because we'll have some intro material to cover. Right? So the intro material is really easy just to give worded questions and give you a worded answer. Like what is the, what color is air on x-ray or something like that, right? There'll be some of those. There will be questions with pictures that you have to use to get to the answer. And there will also usually be 1 or 2 questions where your answers are x-rays. And so we'll present something and we'll say, pick the x-ray that correlates with this, right? This injury, this concern, this diagnosis. Very few of those, because I try not to bog down the system too much. 1, maybe 2. But yeah, ask lots of questions. Happy to answer them on break, right? Email me in Canvas if you want to meet with me. I'm here for you guys. From scheduling purposes, this wasn't on the schedule, right? So what does that mean? That means we have an extra lecture block here. July 16th. Okay, the lecture block on July 16th, that's what this is. We're replacing it with that. All right, so for your class and scheduling purposes, class leader, that kind of thing, I think it's an 8 a.m. lecture on July 16th. I don't need that one anymore because we're doing it here today. Okay, so if you guys want to fill something in with that or however you work it out with the other instructors, that's up to you guys, but I will not be using that 8 a.m. lecture on 16 July. Questions before we jump into things? All right. Radiology. Bones, right? Lots of bones. Hopefully you all remembered all of your A&P because this is going to be helpful in here. You piece it together, right? The different films in that aspect. This is just kind of showing you what x-rays look like in case you've never seen them before. How many have never looked at an x-ray before, like legitimately? Like, be honest, okay. Yeah, good. Okay. Are there any rad techs in here, former rad techs? Can you just not say anything because you don't want to raise your hand? All right, this will be the first class in like 4 semesters that I haven't had at least one. And I like to know that, so that way some of the questions I don't ask them because I know they're going to know it. Okay, so these are the kinds of things we don't want you to miss, right? That big guy right there, that's a problem. What we're going to learn in this block in particular is, what do we do with this? Like, not treatment-wise, right? But where do you think this patient is going to need to go? Ortho, right? They need to go to ortho for sure. Maybe surgery, right? I heard surgery, but ortho's going to make that call, not necessarily you, right? Well, especially in this first block, how are you going to explain this to ortho? Right? How do you describe things? How do you analyze things? How are you going to put it in your report? Because when you call up ortho at, say, let's say you're in the ER at 2:30 in the morning, you better believe they only want to hear the pertinent details of what's going on so they can paint the picture in their head of, can that wait or do I need to come in? So a lot of this, what we're going to learn is not only what bones are they, what kind of fracture is it, how do we talk to ortho, that kind of thing among reading this stuff. This might be some of the stuff you guys will see, especially those of you guard reserve. How many guard reserve? Right? So I'm going to talk a lot about military medicine. I apologize, it's just what I know. But I will kind of caveat into some of that stuff is that you will see things a little bit differently when you're out in the civilian sector. A lot of things I'm like, oh, you won't really see this in your population. Well, those of you who are guard reserve, you probably will, right? This kind of stuff, you may see, right? This is classic trauma type stuff. This patient survived, by the way. This patient survived, right? And it goes to show you why we do multiple views, which we'll talk about, right? Because when you look at the far on your left, the far left image, right? We're like, oh man, this looks like it's right down in between the eyes. But then when you get that side view, or what we call orthogonal views, you realize, oh, it's really not. It's actually more posterior, right? So it just goes to show how important those two views are, and we'll talk more about that later. How do you succeed in this class? Know your anatomy and physiology. When you go through the slide deck, that reminds me, block 1, if you downloaded it, good to go. No major changes in block 1. If I come across a minor thing, I'll let you guys know. Please, if you've already done it, I'm sorry, but don't download block 2 yet. I'm still making edits and changes to block 2. I'll let you guys know when I have it loaded. I know I'm your last test of the semester, right? But I'll make sure I let you guys know. So please don't waste your efforts downloading block 2 yet. But know your A&P. When you look through the slideshows, you will see that I do have some A&P slides in there, right? That's for easy reference for you guys, so you don't have to go all the way back to your A&P lectures to find that stuff. I won't spend a whole lot of time covering those A&P slides because you've already kind of hit it. I will spend some time on the x-ray showing you where those anatomy portions are and what they look like from a bony standpoint, right? But you really got to know your A&P. Pay close attention to detail. It's radiology. We're looking for abnormalities, so you got to watch that stuff. Follow a systematic approach. We'll talk about that. There's 60-something of you in here, right? There could be 60 different ways you read an x-ray. I don't care, right? Your way may be different than my way, may be different than your entire row's way. As long as you have all the criteria that you're looking at, and it's in a system that you know, and you're going to do it the same way every time, it doesn't matter what you look at first, right? It matters what you look at last, which I will talk about. But how you do it doesn't matter as long as you have your own system. That is how you know you won't miss anything, okay? Comprehend, understand the material. This is kind of what we talked about. Don't rely on your ability to just memorize things. The images in the slides will likely not be the images on the test, right? So you won't be able to look at a picture of something like psoriatic arthritis and be like, oh, well, the marker that says right is right in that corner and tilted that way. So if I see it, I know that's the condition. That's not going to work, right? So don't do that. Focus on understanding the material. Throughout the slides and the notes, my notes are not. You don't need to know my notes to pass the test, right? Right? The notes are in there for 2 reasons. One of them, some notes for me to make sure I cover some stuff in case I forget an example or whatever, right? But the other thing is I've had a lot of questions over the semesters that maybe get a little bit deeper than what I need you guys to know, right? But some people are interested in that stuff. So I've taken those over the semesters, put that in the notes for those that like to learn a little bit more, read a little deeper into things. So what I'm saying is that if you don't study the notes, you'll be fine. I don't pull factoids from the notes. It's not going to be like after the test, be like, oh, well, that was the note in slide 45, but it wasn't on the slide, so haha, gotcha. I don't pull questions from the notes. They're there to supplement the material if you want to use it, okay? So don't stress about that. There will be a website coming up called Radiopedia. This is the best practice website I can give you for you to look up images, okay? Like you want to look up when we get there a green stick fracture. I gave you 1 or 2 in the slides. You want to see more of them. You go to Radiopedia, you search green stick fracture, images galore, okay? Don't use Google. Do not use Google, okay, or any of the search engines, because they don't verify that whatever's on there is accurate, right? They don't, whatever those sites are, they're not verified. Radiopedia is verified. It is a medical website that can be used and is verified. A lot of them are case studies, right, that people have done. They put the images up there for you to see. And just practice, practice, practice. Happy to meet with you guys to go over images as we get there. This is just some slides for you to go through if you're on the website, kind of how to get to the actual book. I think we're on version 5 now, but it's the same process. If you have any issues searching, how many actually use the online books? Okay, great. If you do, and you have issues finding it, please let me know so I can talk to the librarian, right? It's rare, sometimes people do, but if there's any issues, let me know. So that's what these are just showing you, how you can get to the book and read it digitally if you so desire, as opposed to the slides. All right, and then through the lecture, comparing images. I will try my best, I can't always do it, but a lot of the times, I will have a normal next to the abnormal, okay? Most of the time, unless I tell you, your normal, as you're looking at it like this, is gonna be on your left, in all green boxes, but before they do, and your abnormal is on your right. I do this so you easily can look at what normal is and what abnormal is and be able to pull that out. I will not be giving you a normal and an abnormal on the exam to compare. You will have just one image, right? But this is the learning part of it, so these are in a lot of these slides I try to show you. Sometimes the normal's on one side and the abnormal's on the next, but I try to give you those to kind of compare to. So what we have here is a normal shoulder x-ray in the green box, okay? And then we have the abnormal. Does anybody know, feel free to just shout it out, what the abnormality is in the red box? Dislocated shoulder. Good, I think that's a fair assessment. Anterior or posterior? How many say anterior? How many say posterior? Couple? Right? Yeah, yeah. Trick question, you can't tell. Right? You will be able to with other images, but specifically in the shoulder, you cannot tell with just one. And we'll talk about that when we get to the shoulder. Trick question. Looks can be deceiving. There's the abnormality. Big giant toe. Alright, so it's just more book stuff, kind of talking about dislocations, subluxations, just showing you how to look at the book and if you want to use this online. And here's an example question. Now, we're going to practice this early, right? Because I want to teach you some test taking techniques that you may or may not have already developed. So a lot of times I'm earlier in the sophomore semester, so like this is more beneficial as you kind of come into this semester, but still want to provide it, right? So we're going to look at a 37-year-old male who's an MBA and experiencing 9 out of 10 shoulder pain. X-ray imaging is accomplished and provided below. What option best describes the abnormality? Now, before we just jump and try to figure out the answer, right? We're going to roll through and we're going to use some test-taking techniques to try to figure out what things can it not be, right? So a lot of times in radiology and some of these other clinical things, it's a lot easier if you rule out the answers that you know it can't be prior to going into it. So how I would do this when I was testing is, I wouldn't even have read the vignette. I would have started with, what option best describes the abnormality in this x-ray? Okay, now I know I'm looking for an x-ray abnormality. Let me go to my choices and see what my choices are so I understand what the possibilities are. I read A through E. I go, okay, right shoulder anterior dislocation. Okay, maybe. I at least got a shoulder there. It looks like it's dislocated. That's a possibility. Bravo. Salter-Harris 5 fracture. You don't know what Salter-Harris's are yet, but when you do, you will be able to rule that out. Right? Because a Salter-Harris fracture is only something that can happen in pediatrics. You don't know it yet, but by the time we get there, you'll be able to look at this x-ray and go, that is an adult, not a pediatric. So, you'd be like, boom, bravo, can't be that. C. Femur dislocation. Well, if you know your anatomy, that's ruled out, right? It's not a femur. Guys, you laugh. You laugh. I wish I could stand up here and tell you that there have been 0 people who have chosen femur with a humerus x-ray or chosen humerus with a femur x-ray. I wish I could, but I can't. So take your time, and I'm sure some of it was fat fingering, right? So take your time when you're looking at it. So we know it's not Charlie. All right, delta, left humeral fracture. Well, we at least have a body part, so I'll take that. It's at least the right bone, so maybe an echo left shoulder dislocation. Okay, so now I'm already down to alpha, delta, and echo just by looking at the answers. Okay, so now I can roll through and I can take a look at this. And now the question is going to be, does anybody know if this is a right or a left shoulder? Yeah, right. We're going to go over what that is. It is a left shoulder. It is a left shoulder, and you'll be able to do this by the end, right? So when you get to the exam, now you're down between delta and echo, and so ultimately we go a fracture or a dislocation, right? It's clearly a dislocation, right? But what you gotta be careful sometimes is there a fracture we're missing? There's not in this one. It is a dislocation, right? But before I even got to the vignette in the x-ray, I dropped it down to really a 50-50. Because you'll be able to tell right from left by the time we get to the exam on certain body parts. So you see how I did that. Now I'm going back to the vignette going, okay, what else do I need to know before I figure out what my answer is? This is a classic wonder where you don't even need the vignette. If you know how to read the x-ray, you can find out there's no fracture there, there's a left shoulder dislocation, and you're moving on, right? So just some styles and techniques when you get to some of these questions. Systematic approach. We're going to talk about it a little bit more and probably ad nauseum in this block. But when you're in clinic, the first thing you're going to do, correct patient, correct image. That needs to be your first step every time in clinic. Now, I don't have a patient in front of you, so testing purposes, right? There's no correct patient, correct image because I'm giving you the image that is for the patient. So there's no risk of you doing malpractice and accidentally reading Jane's x-ray for John, right? That can't happen on the exam. But I'm telling you in clinic, this is the first thing you've got to do. Verify it's the person you ordered on, verify it's the right body part. Because you can have multiple John Smiths, one's a right shoulder, one's a left shoulder, one's a right knee, especially for those of you in the Guard Reserve, if you end up going into like any kind of urgent care, ER, where things are much more fast paced, you're gonna be looking at a lot of images, right? So just make sure you're doing that. The way I have this set up, it's my approach, right? So it doesn't matter if you do it in this order or not, but we're gonna go over it in detail. But I evaluate the cortex integrity, which is the hard white part on the outer part of the bone first. And I do all of it. I do the whole x-ray. Every single bone that is on there, I trace every cortex and look for any breaks, and we'll look at it together. Then after that, I go through the medullary bone, look at the texture of the medullary bone to make sure that looks uniform and like it should. Right now, a lot of you are looking at it going, I have no idea what it's supposed to look like, right? The way we know things are abnormal is how? Learning normal. You are going to see tons of normal, and then all of a sudden I'm going to pull up an osteoporotic x-ray, and you're going to look at that medullary texture, you're going to be like, oh, that's different, right? Because you've seen normal over and over and over again. So I do the medullary texture, then I do the joint alignment. So let me go back. Looking at the joint alignment, right? Knowing that the humeral head should line up nicely with that glenoid fossa, and whoops, that doesn't do that. That's supposed to be over here like this, right? So looking at all the joints, making sure things are aligned appropriately and the spacing is appropriate. After that, I look at the joint spacing, which I just said. Then I look at all the surrounding soft tissue. All of this soft tissue, right? I got skin here and then muscle. So you can see the skin and the muscle, and that's based off of the density of the parts of the body. And we'll kind of cover some of that so you get an idea what that looks like. But it's important to look at the surrounding soft tissue because the soft tissue can give you clues to what's going on sometimes. Is there air in that soft tissue that shouldn't be there, right? Is there shrapnel in there, right? So what can I see in that soft tissue? And lastly, this is the one I need you to keep last, is the area of concern last. Because what happens if you jump in and you get this, you're like, oh, boom, shoulder dislocation. Great, that's what you have. Maybe you miss a couple of rib fractures, right? Maybe you miss a small pneumothorax up here, which is block 2, right? Because the big scary thing that you were concerned about, there it is, I focus in on it, I'm done interpreting this x-ray. I need you to get in the habit of looking at the big thing that jumps out at you last. Make a note of it, great, see it, but I'm gonna go through my systematic process and make sure I kind of hit everything, and then I'll come back to that abnormality. That's just the hardest thing to do when the big shiny object shows up on an image. Because we're all raccoons, we love big shiny objects. It gives us our answer, right? All right. There was our answer, we got there together, left shoulder dislocation. And this one question, here's the fun part about it, who looks at the syllabus? I didn't look at a single syllabus in all phase 1, right? But if you were to look at the syllabus, this one question takes care of like 6 tasks on one question, right? So just to kind of give you an idea how easily we can hit those tasks, I will tell you in phase 2, you need to look at the syllabus. You need to look at the syllabus. Because there are things on the syllabus that we don't teach you here that are now testable in phase 2 that weren't in phase 1. So use it in phase 2. All right, where does radiology fit in your SOAP notes? You guys started writing a little bit SOAP note. You're going to get more of that in ClinCore next semester, right? And then you guys did your subjective, I think, as med history and as freshmen. So where does this fit? Usually objective. Yeah, big highlighted word, right? Objective. Objective if, and in this course it will fit objective, you have the image or you have the results, right? Because it's an objective finding. It's no different than a lab that you order and you have the results. You are diabetic because your A1C is 6.8, right? And I've done it twice, and so you're diabetic. That's an objective finding. You have a fracture because I have this x-ray. It's an objective finding. If you don't have the image and you're telling the patient, I want you to go and get an ankle x-ray, right? And then I'll let you know what the results are. That goes in the plan, right? Because your plan for that patient is told patient to go get left ankle x-ray and we'll contact with results, or we'll report back to the clinic after that, or something along those lines, because you don't have the findings yet. That goes in the plan. You'll learn more about that next semester, but for this course, it's almost always going to be objective because I'm giving you the x-ray, so you'll have the results. This is a reading list. This is not anything you have to read. You do not have to read anything extra for our course. This is just kind of telling you the reputable sources to kind of look at things. So Radiopedia is right there. All right. I think there's actually an A in Radiopedia, but you can Google it. It'll pull up the right site. Yes, sir.
For Radiopedia, is there a way to get it for free?
It should be just naturally free. Did you try to like log in or something? Is that why?
It says purchase some.
Just click in the search bar and type in green stick fracture and see if it pulls up. Yeah, it should just pull up. Yeah. Don't sign up for anything. I didn't notice that they changed their main page. Don't sign up for anything. In the upper right hand corner there is a search bar. You should just be able to type your abnormality there and it should pull up cases and images. Yeah, you should not have to pay for it. POCUS.org, that stands for Point of Care Ultrasound. We'll hit a little bit of that in this course, and you can just use it for reference if you want, but you don't have to. Ortho bullets, this will be beneficial in your career, save that one. Orthobullets.com is a great way to evaluate what ortho would do. What would ortho tell you if you didn't have ortho down the road, right? If you have a small facility like Edwards, then ortho is 45 minutes away in the civilian economy, and I can't just call up an orthopedic surgeon and ask them what to do with this patient. You put the referral in for ortho, you can use ortho bullets to help you manage the care for that patient based off your x-ray findings. Up to date is just a standard one we use all the time in clinic, right? And then it's on there because someone asked for it. Don't get so hung up on this intro to radiology.net. It goes way in the weeds, right? Stay out of the weeds for this course. Do not go into the weeds. And then don't use Wikipedia and don't use Dr. Google for radiology. Bad news. All right, intro. Jump into it. Looking at x-rays, where do x-rays fall, right? On the light spectrum. We only can see the visible light spectrum, that small little bit area, right? Infrared's your TV remotes, microwave going on that way, we know what microwave and radio does. X-rays are shorter wavelength, higher frequency, higher energy, right? It's not quite gamma rays. We're not going to turn into the Hulk by doing too many of these things, right? You're not going to hurt your patient in that aspect. But it is a harmful radiation, right? So we have to be vigilant on how much we're giving patients and is there another way to do it that doesn't involve radiation to get us the answer we need. And we'll talk more about that. But just know it is on this higher energy, shorter wavelength area, higher frequency as well. Okay? So what does that mean? That means we can cause damage, like I was saying. What ends up happening is the energy from the x-ray will hit any of the electrons that are in your cells and knock those electrons out of orbit. Okay? This is in general, let's get up with radiation, the gamma rays, right? The nuclear stuff like Chernobyl or 3 Mile Island, right? This is what's happening. It's the same style stuff, it's just at a higher level. So what happens is it knocks out the electrons out of orbit, it changes the makeup of that cell, that's what leads to cancers and bad news and all that stuff. So yes, too much is a bad thing. The amount of radiation you give in an x-ray, a regular x-ray, not a CT, right, a regular x-ray, is so minuscule that you should never be concerned about giving that to a patient unless they are a child or they're pregnant. But if there's no other way, then we will. But if there is, then we'll try to avoid it. And we'll talk about that as we get to it. There's protective measures that we can use, right? The x-ray techs, the rad techs, they'll use shielding, they'll use lead shields to protect certain body parts when they take the x-ray. So there are measures out there to protect yourselves as providers, the patients, and things along those lines. These are the areas we're concerned about the most. Here's your first chart. I know you're done with Clin Lab, so I know you all love charts. But there are people that learn this way, okay? This is super important. You really do need to know what body parts and what organs are most affected by radiation, right? Because as we get into things, if there's an ovary concern or a testicular concern on a patient, do I really want to order a radiation study? No. This is why, which we'll get into, ultrasound is the test of choice for testes and ovaries because there's no radiation involved with ultrasound. So it's perfectly safe and we don't spin them through a CT scanner, okay? So knowing what body tissues are highly radiosensitive compared to low is really important. Why do we use X-ray and CT for a lot of stuff? Well, look, muscle low radiosensitivity. Most of our organs from a CT standpoint that we're going to use to evaluate, very low radiosensitivity, right? Bones, very low radiosensitivity. So overall, it is generally safe to use radiation to evaluate these body parts because of how low they are. But be very concerned about the high radiosensitivity ones, which is why those lead shields that they use will cover the testicles or the ovaries on women if we're trying to even get like a shoulder x-ray. They're going to block this part of the body so that way the lead absorbs the radiation and it doesn't get to those organs. So these blue slides, right? They're sprinkled throughout to kind of break up the dark black slides, right? Under Canvas, there's like a review slide deck that you can download, and it's basically just the blue slides from all the lectures. You can use this as a good kind of check on learning for you guys for the general concepts, right? This is not like a test review or like, you know, all the answers are in the blue slides kind of thing, but they're checkpoints based off of common questions that I've gotten through the course, right? So I made them blue slides as just kind of checking on things. So we'll kind of blow through them here in class, but they're just for you as you're going through and studying to check your own learning, or you can just download that review slideshow on Canvas. And every once in a while I'll throw cartoons in there. Little old ladies always get concerned about the radiation. I've already had like 45 nanos and this. Are you sure it's safe to get a chest x-ray? Yes, it's safe to get a chest x-ray. Little fun fact for people that you can use in your clinic. You get more radiation absorption in your body from a round trip flight, anytime you fly, than you do from a standard chest x-ray, PA lateral chest x-ray. Use that for your patients, it'll make them less afraid. All right. So we just had the chart, right? So check on learning there. What tissue is most susceptible to radiation? Testes, alpha, good, right? All right. Plain films. So a couple of vocabularies we're going to go over. That is pronounced Rankingram. Don't try to say it unless you're going to say Rankingram. That is William Rankin. We'll talk about him. He invented x-rays. We're going to talk about attenuation, what's radiopaque, what's radiolucent, what are orthogonal things. We'll cover the history stuff. History is background knowledge. I'm not a factoid historical guy, right? I am not going to ask you, in what year were x-rays discovered by William Rankin? I am not going to ask you who discovered x-rays. Don't waste your brain power on the history. Background slides only, okay? But for those of you who are curious, 1895 is when they got discovered by Wilhelm Rankin. It was first industrial, but he found a way to try to use it in a human setting. What you have here is an x-ray of his wife's hand that he used her to experiment on with her consent. But there were no regulations back then, right? They were just trying to discover this stuff. There was a lot of radiation that was being used when he was inventing these things and taking those pictures over and over and over again. He actually caused this damage that you can see to her hand just from repeating the x-rays and everything. It caused bone cancer and all that other stuff. But now we are here we are today. They call them x-rays because originally when they were invented, they didn't really know what they were. Like, it was X for unknown. That is literally where they got their name. It's an unknown thing. We don't know how it works, but boy, it's letting us look at the bones. That's kind of cool. And so they started using it in 1896 with battlefield surgery. Here's what the machines look like, okay? So what you have is two things. You have the one with the bed and the table is your standard radiological suite. That's when you send somebody to the radiology department to get their x-ray done, right? This is what they're doing. They're either lying on the table or standing up on that board up against the wall to get their x-ray done. What you have on the right-hand side is a portable x-ray machine. This is one that wheels around the hospital and is portable, and this is what you'll see a lot of times in like your inpatient wards, your ICU, maybe the ER, if they don't have their own radiology room. You can bring this right to the patient's bedside and take whatever x-rays you need, for the most part. There's a few that can't be done with this one, to be able to get those images to the ER. So these are the two different types of things you may see when you're out in your phase 2. And here's what they produce. They produce standard two-dimensional images. Yeah, two-dimensional images. Your mind and your brain is going to try to play tricks on you because we like to see things in 3D. That's how we live, right? So when we see some of these things, our brain tries to interpret it in 3 dimensions, which is why on that shoulder dislocation, so we're like anterior, posterior, well, because if you look at it, your brain is trying to extrapolate a 3-dimensional image from something that's 2-dimensional. So just remember, these are 2-dimensional images. So what does that mean? Why do I need 2 pictures? Well, the only one here that has 2 pictures that go along with it is my tib fit, right? So I got my frontal view or AP view, which we'll talk about, and then my side or my lateral view, okay? To be able to see it from 2 different angles because it's a 2-dimensional image. So I need to get 2 separate 2-dimensional images to then piece together what is my 3D thing, like the nail in the skull that we saw, to make sure we have the most information, all right? So a lot of times we need multiple films to assess the body part. For example, is this a right or a left hand? I don't know. Why? Because was the hand like this or was it like this? I don't know. Is the anatomy to my right and left hand the same? So if I did this, could they look the same on an x-ray? It's very possible. Right? They look like different hands. They could be different hands. I'll tell you they are, but then the question becomes, is this the same hand? Right? So why is this important, right? I show this to you because there are certain body parts you can look at it and you can say that's right or left without being told. And we will go over that and you will know which ones those are. What you should have on these x-rays is a little R or L in the corner telling you if it's a right or a left. That is standard operating procedures for your rad techs. They should tell you that, right? Without it on something, you can't tell. A knee is another perfect example. Both knees look exactly the same. If I just give you a knee x-ray, and I'll tell you if it's left or right, you can't determine if it's left or right. Unless you were the one that shot the x-ray, and none of you are really ever probably going to do that, right? So just make sure you know what you're looking at, and just understand things can look the same. What does that mean? I'm not going to trick you on a test, right? It will have a marker on there if you need it, okay? The only ones that I won't have a marker on intentionally will be the ones that you should be able to tell if it's left or right just by looking at it after we learn how to do that, okay? So I'll have a marker. If for some reason I give you a hand x-ray, right, and it doesn't have a marker on there, and the vignette says patient comes in with right hand injury, it's a right hand, guys. I'm not into trying to screw you over and be like, it was left hand. No, I'm not doing that, right? You can use your context clues to piece that together, okay? Just so you're tracking on that. That rarely happens, but I'm human. YouTube doesn't work up here on the podium for me. However, this is in your slides. What all these YouTube videos do is it gives you a short 2 to 3 minute video of how x-rays are produced. How does the machine make it? What does it do to help you understand how it works, okay? And this is what we're showing you. All right. So, quick cliff note version of overall what's happening. Electrons are being, that's bad, we're not gonna stand there. All right, electrons are being created here by this cathode and being shot toward this anode thing. These are just electrons right now. This thing is spinning at a high speed. Okay, I think it's made of like tungsten or lead or something like that. Not lead, tungsten or something like that. And it hits, it's angled, so the electrons hit these things and basically shatter, for lack of a better word, and turn into radiation or photons that then get shot down towards the hand. Gets absorbed by the hand in the different body parts and gets projected here on this film afterwards. That's the generality of how a regular plain old x-ray works, okay? So what you're looking at now is a patient doing that. So the x-ray, all what we showed here in this slide, all of that is happening right inside this machine. It's all happening inside this machine. So what comes out is just what we call photons or x-rays, and it's coming down into the patient. You can see, although it's not aligned, the film is in the bottom of the table here. So this was clearly a staged photo, right? Because we're not seeing any of this because there's nowhere for it to project onto, right? But ideally, this would be directly underneath her, and it's going to x-ray her chest, and the image is going to be produced right down here, okay? This is an upright one. We like to do uprights for the chest to get a full view of the lungs. We'll get into that in block 2. Why is she set like that, right? AP versus PA. So there are negative things that go along with our films. There are challenges that we have to interpret of, is this an abnormality or is this just due to a flaw in the system, okay? One of the most common ways to look at that when we're talking about is our magnification. All right, by sheer nature of shadows and lights, if you're ever doing this someday, just kind of think about it, right? Take a light and put your hand up against the wall, okay? Get your hand really close, shine your phone flashlight on it, and you'll see a projection of your hand shadow around the same size as your hand, right? Keep the light where it's at, move your hand further away from the wall. What happens to the shadow? It gets bigger, right? It's projected bigger. This is just a game of shadows. That's what x-rays are. They're a game of shadows, right? So when you take an object farther away from something, i.e. the heart, and you move it farther away, you're going to have a more enlarged heart than what the patient actually has. We'll get more into it. This is just intro, so don't bang your head against the wall yet. But that's an example of why we always will do an image in a way that puts the body part of concern or the large area as close to our film as possible, to decrease that magnification, right? As you can see, when I'm flipped around the other way, I have all this extra space here for that heart. It's going to look enlarged. And I know right now, looking at a PA chest and AP chest here, you guys are like, they look exactly the same. They are slightly bigger. If you just kind of look here on this part of the heart compared to the AP side, the AP is slightly wider and larger. You don't need to worry about that for this particular block, right? That's going to be a block 2 thing. But just to help you understand that magnification process and that issue. It's another example to kind of show you the difference between a PA and an AP. You can see the heart kind of ends right here, but then this one, it projects all the way out to that thorax wall, right? Ends here. When I flip them around and do it differently, look how large it makes the heart look. You can easily misdiagnose this with a cardiomegaly or a large heart if you don't realize that this was done in an AP versus a PA. Okay? Good news about this, guess who orders the images? You guys, right? The only way you're ever going to order this is if it's a patient like this. What do you notice about this patient compared to the one on the left that says PA? What's on the AP that's not on the PA? What do we see? Right? Someone said pacemaker, right? I'm seeing clips and wires, right? These things are not part of the anatomy. This is not part of our normal anatomy. That means this was an inpatient, which means they're probably bedridden, which means asking them to stand up and get out to get like that true, put your chest up against something, probably not going to happen. They're also not going to ask them to roll onto their belly to do a chest x-ray, right? So they're just going to throw the plate behind them and get the best they can with the patient's status. Now, you probably ordered that, so you're already going to know that, so you're not going to be like, oh my goodness, look how large our heart is. No, because you're already anticipating that. By the time you get through all of phase 1, all of phase 2, you'll be good at this. I will tell you, right, exam-wise, even for block 2, I will tell you if it's AP or PA. I do not expect you to get to the level to look at it and determine, oh, that's an enlarged heart because it's magnified because without me telling you that that's how I shot it. I don't need you guys to be radiologists, right? I just need you to be aware of pitfalls when you're looking at images by making interpretations that may be incorrect because of the position of the patient. Here's the way a lateral chest x-ray looks like, and just in general for any of the images, we're always going to do a frontal, PA, AP, and at least a lateral view. Those are my two views, so that way I can get that three-dimensional picture, right, off of two-dimensional images like we talked about before. So here you can see the heart in the anterior portion. You can see the spine really nice, which we could not see that well here. Some poor technique, but it gives us those two views to look at both sides. All right. CT versus MRI. What do we see the difference on these things? Anybody notice anything that stands out more on one versus the other? System settings, right? So right here, primarily the bone areas, right? The hips. And we'll get into that. See how bright and white the bone is? And how in the MRI it's not really that bright, right? And then look at the muscle around kind of the hips, right? It's there. We know it's there. It's not super clear, right? It's kind of just muddled right around the bones. But then when I get into my MRI, right, look at the detail I have in the muscle. I can even make out different muscle areas, subcutaneous fat, right? This is actually subcutaneous fat down here, but it looks a lot the same as muscle. On the CT, this is subcutaneous fat. It looks really close to muscle, but look on that MRI, I can really see the difference, right? So what does that mean? CTs are going to be used still for bony checks in some organs, and we'll talk about that when we get there, but MRIs are great for muscular things, tendons, ligaments, labrums, things like that. Not great for bone, okay? So when you're going through and deciding what kind of image do I want, by the end of this, you're going to know, but definitely be able to tell the difference between what a CT looks like and what an MRI looks like. Look how grainy the CT is, right? So the way I like the word is kind of grainy when compared to the MRI, and how smooth the images are in the MRI, how that muscle and subcutaneous fat kind of jumps out, whereas on the CT, the bone jumps out. Understand those differences, because you got to be able to know what kind of image you're looking at and what modality was done. Even though you ordered it, right, you may not have ordered it. You may be coming out of the shift change, especially if you're in the ER or something, and the patient's down at radiology, and they come back, and all you got is the study, and you haven't know what's going on yet. Know what you're looking at in that aspect. Don't worry about that one. All right, we're going to do this, and then we'll go on a break. All right, different shades of gray. That's how we talk about things in X-ray, right? There's black and there's white, and then there's multiple shades of gray. All right, so metal is white on X-ray or CT. Metal is white. Bone looks white. Bone is not white. Bone is very bright gray. Okay? I know. Just work with me here. Metal is white. And there will be some images we will see. You will see the difference of metal compared to bone. And then you'll go, oh, okay, yeah, that metal is brighter. Metal is white. Bone is very light gray. Okay? Air is black on X-ray and CT. Air is black. So why is that, right? What ends up happening is we shoot the X-rays towards the film in the body part, right? The film is designed to turn anything that gets hit with radiation, or the photons, black. So if I just take a plain film, shoot an X-ray on it with nothing on it, the whole thing is going to be black. Because all the X-rays did was go through air, which is why air is black on X-ray and CT. Metal completely absorbs and blocks or reflects all of those X-rays. So that's why it's bright white. There was no radiation that made it through the metal to get to the film. So it didn't get exposed at all in that area. And then we have different levels of density. So bone being more dense than soft tissue or muscle, being more dense than fat. So the more dense the object, the lighter gray it's going to be. The less dense, the darker gray it's going to be. What is fat? Fat is mostly water and fluid, right? So a lot of those radiation, a lot of the X-ray is going to penetrate through that and get to the film, which is what gives us that dark gray. Well, muscle has a lot of fluid, it has a lot of water, it has blood, right? But it also has fibers, it has tissue. which means it's going to absorb a little bit more. So that's why you'll see a little bit of a difference on that one x-ray. I was like, look, this is skin and this is muscle. How I knew the difference was the density of the tissues, right? It's going to be a little bit of a lighter gray for muscles than it is for skin. And then bone, more dense than any of the other stuff. That's going to absorb the most body part wise, and so it's going to be that really light gray. We will see more examples of these as we go through the x-rays. But from there, let's go ahead and take a 10-minute break, and then we'll see you guys at the top of the hour. You guys are sitting here going, oh my God, how am I going to remember all this stuff? Like, this is thick. What's light gray, what's white, what's black, right? This is the challenge with the first lecture, right? I gotta get the foundational definitions and descriptors out there. Once we start putting this into practice, it'll start to come more natural, okay? So one thing I didn't talk about before we go on break on this slide, words that I will be using, and that you will be using in clinic, but words that I will be using as we talk about things is on the bottom of the corners of the chart here, radio-opaque and radiolucent, okay? So it's on those parts of the chart on purpose. Radio-opaque is meant to be something that is more opaque when exposed to radiation. So it's denser. So bone is more radio-opaque than soft tissue. Right? Metal is more radio-opaque than everything else. Radiolucent, lucency goes through it, right? It absorbs less of the radiation. So fat is more radiolucent than soft tissue. Okay? So when we're describing things and we're pointing stuff out, I will be using those words to be like, look, you see how much more radio-opaque this is than this object, or more radiolucent than this object. This is in terms of x-rays and CTs, and mammos, because they use radiation too, right? X-rays, CTs, mammos, radiation. MRIs, which we'll talk about later, use magnets, not radiation. Ultrasound uses sound waves, not radiation. Those are going to have different terms. But radio-opaque versus radiolucent. Instead of me saying more gray or more black, right? We're going to use big boy and big girl words. So that way when it's in the radiologist report, we know what it means. All right. Questions on this stuff so far? Okay. Here's a really good image of talking about those different tissues, okay? Primarily, looking at the metal on this x-ray, i.e. the earrings, the necklace, and what this is called the marker. Remember I talked about that right versus left? This is what should be on most x-rays. This tells you it's a right shoulder. You'll learn later you don't need this for the shoulder. You can tell it's a right shoulder just by looking at it. The JT here, Justin Timberlake shot this x-ray, okay? Those are the initials of the x-ray tech most of the time. And that's really beneficial when you're in some of those ER urgent care settings, right? Or if you're in an inpatient setting, because if it's a crap x-ray and you need to repeat it, you know who did it. So you can just call right back to, don't be mean, don't be a jerk, right? Be like, hey, you didn't really get this. It wasn't, can you come back and do it again? And then come back and do it again, right? So don't be mean about it. These little beads right here, inside of there, this is a good way to tell something. So what do we think? Do we think this x-ray was shot standing up or laying down? Laying down. These are gravity beads. So when it's flat, they pool in the center. When the x-ray is done upright and they're sticking it on an upright film because it's standing, those three beads will pool to the bottom in a nice little straight line. So it's another indicator for you guys of kind of how the x-ray was shot. But look at how white the metal is compared to the bone. Now do you see why I say metal is white, bone is very light gray. There is a difference, okay? But then when we're looking at the different soft tissues, so we have our bone here, we got our cortex, which is definitely more radio-opaque than our medullary area, right? Why is that? Because the medullary bone is less dense than the cortical bone, so that makes sense. Then I move into my muscle, right? Nice deltoid muscle there. And then my subcutaneous fat, or actually we just say skin, but really this is just some fat here. And then the air. Because this is all part of the film, right? So again, cortex, medullary bone, muscle, fat / skin, air. You can see how it gets more radiolucent as you get through those objects that are less dense than its counterpart, right? Now, full disclosure, when you get large fluffy patients, you may not be able to tell the difference between the muscle and the subcutaneous fat because there's a lot of it. So it just kind of looks all the same. That's okay, right? There's not many instances on a regular x-ray that you're gonna need to sort through these kinds of things. We'll talk about a couple of why it's important to like outline where the edge of that subcutaneous fat in the skin is when we get there. But there's not a whole lot of times when I'm going to look at you and be like, well, which one is muscle and which one is subcutaneous fat? You do need to know that scale that we did of the radiolucent to radiopaque, right? Okay, and we'll talk about that more as we go along. Here's another example of metal versus bone, right? So this patient had a total knee arthroscopy, or TKA, or total knee replacement, right? And we have the metal in their knee, and we also have this here. What is that? What is all this? These are the staples from the surgery, right? They had a total knee replacement. So now look at the difference in the comparison of the metal versus the bone. This is why bone is very light gray. Questions? Anybody see anything else on this that shouldn't be there? The dark spots. Yeah, what the heck? Why do I have air in the soft tissue?
Surgery.
Because it was an open surgery. Normal. This is normal because they just had surgery. If I see that and they haven't recently had surgery, it's abnormal, right? There shouldn't be air in that soft tissue. And that's where that vignette or that patient history comes into play. If they recently had surgery and you see this, you expect there to be some air in there. If they didn't, where's the air coming from? Why is it there? What happened? The odds are, in that case, maybe there was an injury or a puncture wound or an open fracture somewhere that let air in, and maybe you can't see it on the x-ray, but you see the air pockets, so then as a clinician, you gotta go back and double check some stuff, right? So, history tells you if it's normal or not. How does air appear on plain film radiographs for CT? Black. Radiolucent or black, right? Radiolucent, I like that you said that, but radiolucent is going to be used as a comparison term, right? And radiopaque. Because I could say air is radiolucent, in this case, it's accurate because it's the most radiolucent, right? But if I were to say soft tissue is radiolucent, well, compared to what? Because it is to bone, but it's radiopaque compared to fat. Right, so just be careful with that. But in this case, it would just be, it appears black. Metal appears what? White. Bone appears what? Very light gray. Yes, not white. Soft tissue, gray-ish, right? Gray-ish. Okay. Now let's talk about some of the benefits and lack thereof for plain films. So plain films is just regular radiology, regular x-ray, those machines I showed you. We're not getting into CT yet. CT is still radiation, but this is just the regular x-ray stuff. What are the pros? Super cheap, guys. Really, really cheap. These things do not cost that much money regardless of what the hospital wants to bill you. They're really not that expensive. It's readily available. Even in your rural settings, because of that portable machine, most of your deployment settings and things like that, even out on the farms, all those places, you're going to have at least a portable x-ray machine. I have yet to hear of a deployment at an aid station or something like that didn't at least have a basic x-ray machine, right? Now, if you're going out, outside the wire with a unit, no, you're probably not going to have it out there when you're on your missions, but at least at your main hub where you're going to be at, you should at least have an x-ray machine. And even at a small base like Edwards, where we were a 4-provider clinic and had no specialty care, we had plain film x-ray. We didn't have a CT, but we had plain film x-ray. So portable, they're quick. Like, they take the picture and you have the image within a couple minutes. Very, very quick, okay? The main con, ionizing radiation. It's the stuff that harms people, right? So we gotta use vigilance when we're doing things on patients that would have high susceptibility to radiation. Pregnant women and pediatrics are your two most common patient populations. What do we use it for? Well, you've seen a lot of chest x-rays already, and that is because, as when we get into block 2, you will see it is the first line image done for almost all chest pathology. A lot of times you can't fully diagnose a patient off of a chest x-ray, but you use it in adjunct to rule out some other stuff. You can rule out pneumothoraxes, you can look for broken ribs, you can look for heart failure, which we'll get to in block 2, that kind of thing, okay? But it's used very commonly in chest, and also because of the tube and line placement. Whenever anybody puts an NG tube, if you put an NG tube in, you need to order an x-ray. You put in the central line, you need to order an x-ray, right? You put an OG tube in, or any foreign tube that goes into the body, order an x-ray to confirm placement afterwards. You intubate, you order an x-ray, right? Because you can see all of these tubes and all these things you're putting in to make sure it's in the right location. Fractures, which we'll talk about, you can definitely see fractures on x-ray in the chest. You can see tumors, and believe it or not, when we get there, depending on the location and the symptoms, you can probably make a pretty darn good educated guess at what kind of tumor it is, just based off of location and symptoms on the chest x-ray. And then pneumonia, pneumothorax, hemothorax, we'll talk about all that in block 2. Abdomen, same thing, it's going to be a block 2 thing, but we use it for bowel obstruction and looking for free air in the abdomen. We'll get into more details on that later. Really, what we're focusing on is going to be these bottom 3. The skeletal system. It is the first line study for almost all MSK pathology. You notice how it's yellow, okay? Throughout this course, we're going to spend a lot of time talking about first line and study of choice. Because sometimes there's a better study to evaluate the condition and the concern that you have than an x-ray. But it doesn't mean that that's not the first thing you do, right? I will have study of choice in blue, first line in yellow, which goes back to reading the question first. What am I asking you for? Am I asking you for first line or study of choice for the condition? That answer might change depending on what I'm asking you. So, first line for most musculoskeletal. Why? Because we're evaluating the bones, which is very well done with x-ray. We'll be able to see fractures. And believe it or not, be able to talk about and see some arthritises as well. Can be diagnosed via x-ray. Foreign bodies, we'll see those on x-ray, and then any kind of trauma is pretty standard. This is just showing you why we can do upright versus supine and laying down, right? So this is the same patient, 2 different x-rays. What I have here is the patient is lying down, supine, that's what that is. And you can definitely see that there's some air in the bowel, right? But what it looks like is just kind of dilated air and bowel loops, right? I don't know if I really see any fluid, it's kind of hard to tell. But when I stand the patient up, now I have all these air fluid lines. Why? Because who's got a clear bottle of water? Nobody. You guys are all drinking out of different things. Okay. So, think about a bottle of water. Marley, give me your bottle of water. Come on. Sit right in front of you. Like, not me. All right. So, think about this bottle of water, okay? If I have you upright and I shoot an x-ray, fluid and air or different things are going to have 2 different densities, right? So I'll be able to see that air fluid level because gravity is doing that. It's pulling all the fluid down. Watch what happens when I lay you flat. And I shoot my x-ray this way. Everything is going through the fluid. So it's all going to look the same. I cannot tell how much fluid is there or if there's air fluid levels when I shoot the x-ray this way going straight down because the fluid and gravity lays it out. When I stand you upright and shoot the x-ray this way, I now get those air fluid levels. Does that make sense? Gravity can be your friend to help you see things. Thank you. Stay hydrated. All right. Okay. Another thing with x-rays, weight-bearing stuff, right? Are they just sitting or are they standing when they take the x-ray? You can see the difference here in the knee. This white arrow is not weight-bearing. Look at how beautiful that joint space is. You're going to see normals later on. You're going to learn that that's a good joint space. Is that a true functional joint space? No. They say it hurts when I stand. It hurts when I walk. Well, then what good is the x-ray when they're sitting down? That's not when their pain is, right? When you stand them up, look at how small the joint space is now. Weight-bearing x-rays give you a better interpretation of what's going on when the patient is doing the things that cause them pain. And I will tell you right now, I order all of my knee x-rays, foot x-rays weight-bearing, because if the patient needs to go to ortho, guess what they don't work without? Weight-bearing x-rays. So if it can be done, do it. Hips are harder to do weight-bearing. Ankles are a little more challenging to do weight-bearing, but like knees and feet, I always order them weight-bearing. Because if you order them regular, send them to ortho, they're just going to get more pictures. Ortho won't see them without weight-bearing films. Look at the foot. So primarily I'm looking at the joint space in between the first and second metatarsal on the normal, that nice little joint space with its weight bearing. This is a normal one. Look at the abnormal one. Look at how large that joint space is. This is what's called a Liz-Franck fracture or Liz-Franck disruption. We'll talk about it later, right? But if you don't shoot this weight bearing, you will miss this. It does not show up because it takes the standing on it to put the pressure to separate out because that ligament is disrupted. But if you're not weight bearing, it'll look like a normal x-ray. So just showing you the benefit of doing anatomical x-rays functional x-rays as opposed to just getting the body part. Another functional for the neck, right? This or cervical spine as we call it. In x-ray, it's not really the neck, it's a different thing. Cervical spine is our flexion and extension views. We will go over the spine and the lines and what to look at later, but the biggest thing is you want to get them chin tucked all the way down, looking up to the sky. It's going to show you the range of motion and the functionality of that cervical spine. Okay? These aren't done as often anymore because CT is so prevalent. We usually just do, like this, just spin them. Just spin them. That's code for putting through the CT scanner, right? Because we get more details, and really we'll get into it, but like the reason for that is it's really difficult to look at the C1 and C2 and the dens on an x-ray to confirm there's not a fracture. It can be really hard to see, so we just throw them through a CT scanner. On top of that, most cervical spine injuries in a trauma probably come with what else? What other kind of injury? Head trauma, right? And head trauma, we're going to throw them in the CT scanner anyways, look for bleeds. So if we're going to send them for the head trauma, might as well just scan their cervical spine as well. So, but this is still an option for you to do, okay? Now, why is there an L sitting there on that? It's weird. Left side of what? It's a side view. That's why you guess what I'm thinking. I always do that, sorry. So, this is your lateral side view, right? There's two ways the patient can stand. They can be standing this way or this way. So what the left means is a left lateral. That means the left side was closest to the film. Okay? 95% of your lateral x-rays, when it's like this, your spine stuff, are going to be left laterals. Just how it's done. Okay? So that's what that's telling you. Is left side is closest to the film. Now, so am I looking at the left or the right side of the spine if the left side is closest to the film? Right? Right? Both. It's superimposed on each other. I say that because I don't want you to get hung up, right? I don't want you to see that left and go, this is the left side of the spine. This is superimposed on each other, okay? You can't tell which part of this vertebrae is the left side of the vertebrae or the right side of the vertebrae from this x-ray. That's why we would need that frontal view. If we saw an abnormality in a fracture, right, I would compare it with the frontal view, which would tell me which side is left and right to go, oh, that's a left-sided fracture, because these are superimposed on one another. Okay? So don't look at that left and go, oh, that's the left side of the spine. I need you to turn around and do one on the right side too. You're going to get the same picture, right? And you're going to get the same view. It's not going to mess anything up. All right. What are some pitfalls and some things? Now, we haven't dove into reading and looking at the chest x-rays yet, right? But things that you need to watch out for. Rotation is important. Position is important. Understanding anatomical position is important, right? Knowing how the body and anatomy physiology works. We know the clavicles are supposed to line up with the sternum nice and pretty right at the end, which is what we see kind of here, okay? Clavicle edges right up against the sternum. That's how it's supposed to be. That's normal. Also something we have normal is you can't really see on the black dotted line, but it looks good on the yellow side over here, is my spinous processes. Where are the spinous processes? They're in the posterior aspect of our vertebrae, which means on projection, they should be right in the center of that vertebrae. And you'll see it better when we get to the spine stuff. So if my patient is standing how they're supposed to, and it's a perfect picture, they should be right down the center, the clavicle should be right up against the sternum, right? But if something happens and I'm rotated, right, it's gonna project differently. So what you end up seeing is gap between the clavicle and the sternum. And so you have to kind of figure out and analyze eventually down the road, right? Is this a positioning error or is this an abnormality? Is there a dislocation of their sternoclavicular joint? That's rare, but it can happen, right? I'm less concerned about that on this one because when I look at my gap of my joint space, I'm like, ooh, that's big, right? But then when I do my assessment, I see that my left clavicle, and it's hard to see here because of the red line, right? They're just making it obvious this early for you. That's why I drew it on there. The red line is projecting into my sternum. So that tells me it's probably a rotational component, right? Because when you rotate, everything shifts. Now, if I had this large joint gap here on the right side, and my left clavicle lined up perfectly, that leads me more to think it's an abnormality because the other side isn't matching up with a rotational deficit that I see on the right side. Does that follow? Right? And that's kind of hard to see right now, but just kind of giving you ideas of how to use your anatomy to help sort through, is this truly an abnormality or is this just a downfall to the positioning of the patient? Orthogonal views. This is an example of orthogonal views. Orthogonal views is the big fancy word for two pictures. A frontal, PA or AP, however it is, and that side view or lateral. Those are orthogonal views. They are two 90-degree views to give you a three-dimensional picture from two-dimensional images. And here's why it's important. This is the same patient. That fracture on this one right here doesn't look that bad, guys. I see it. It's right here. All right? We'll go through my process, and we'll do that a little bit later, but right, it's right there. And this looks kind of weird, but I don't really know why it's like that, but I don't see a fracture there, right? So that's not so bad. So this might just be a, hey, some guy put you in a splint, and you should be just fine. But when I get my orthogonal view, oh, this is a lot worse than that first picture led me to believe, right? Now, I know what you're thinking. You're like, well, I see this patient in the clinic. I'm going to know that it's worse because their arm is bent in a weird shape before I start to put the x-ray, right? Ha ha ha. Uh-huh. Until you're on shift change and you haven't seen this patient yet, right? Or you're covering for somebody because they had to go do a P test, so you're just quickly reviewing the charts and you haven't seen this patient yet. Right? That's always fun here in the middle of the clinic. Hey, you gotta go. Drug test. Anyways, so that's where your orthogonal views are important, right? AP and lateral is really kind of what it is. Sometimes a PA. In reality, the biggest thing is two 90-degree angles. Right? Your x-ray techs will sometimes get creative on injured patients and they'll get what they can get, but they'll always try to get the two 90-degree angles so that way you can paint that 3D picture. So there's only one main drawback to plain films. What was it? Ionizing radiation. The benefits, right? Cheap, readily available, and really quick. Reasons, yeah, you don't need to list them all. You know the reasons. Because if you know why you do it, then if there's a question that says, what kind of study are you going to order? It will help you understand what study you need to order. Right? We briefly talked about positioning, the rotation, the magnification. Those are the two biggest parts for x-rays. questions before we jump into this? So far? Okay. So, let's talk about contrast agents. Now, I'm going to tell you, you're going to see this slide multiple times. Why? It's important. Okay? We don't really use contrast agents very much when it comes to regular x-rays like we've been talking about. But we will use them for CT, we will use them for MRI, and we will use them for some GI stuff with regular x-rays as well. So we're going to go over what kinds they are and the pros and cons to those, because if you give the wrong kind or give it to the wrong patient, you can cause significant harm with these contrast agents. Okay? So, first one. IV or intra-arterial, we're going to mostly say IV for right now. We'll talk about some of the arterial stuff in the next block, but it's the same contrast. It's an iodine-based contrast, okay? The idea is, so we talked about this, right? Soft tissue. It all kind of looks like this gray, right? I'll give you a secret on this. Fluid looks the same as soft tissue on x-ray, which is why when you see the heart, you just see this gray blob, right? The heart's full of blood. It's also muscle. It just all looks the same. It's just they're both the same radiopaqueness, soft tissue and fluid. They're bedfellows. They live together, right? So if I'm trying to evaluate certain veins or lymph systems or arteries, I can't really evaluate how open they are, how well they're working, unless I give you something that makes the blood or the fluid look different. And that's what this iodine-based contrast does. It lights it up like a Christmas tree. You get bright white. So you'll be able to trace the aorta all the way down. You'll be able to look at the liver on a CT and see all the arterial vessels and the venous vessels kind of light up much more radiopaque so it stands out against that soft tissue. That's what the idea is behind this. Now, iodine-based. What happens if my patient is allergic to shellfish? Can they have it? Yes. Common misconception. Different type of iodine, common misconception. I say this so that way you can conservation tell them it's okay. Shellfish allergy and iodine-based contrast do not have any relationship whatsoever. Okay? Perfectly safe to do. We'll get in when to not do this later on. But iodine-based contrast, used for vascular structures. Oral or rectal contrast? Yes, rectal contrast. Right? Barium-based. Thicker, okay, and primarily used for the GI tract. Now, it says that it's used for most, used for most abdominal and pelvic CT scans unless there's suspicion for bowel pathology, right, which would delay a diagnosis. So, we use barium to swallow and drink to highlight the esophagus, to highlight the stomach, to highlight the intestines. The reason we like to use that is, again, it's thicker, so it kind of goes through the whole thing and we'll see it a lot better. That iodine-based contrast is liquid, so it doesn't really spread and kind of coat as well as the barium does. However, in red, red's important. Here we go. If you are concerned for an esophageal varice, if you are concerned for a perforation, an ulcer perforation, or something along those lines, do not give barium. Barium is not water soluble. If it leaves the GI tract, it will be there for a very long time and it will cause an infection. Most commonly, aspiration pneumonia, which we'll see about that later on. You get that patient who's drinking it while they're taking a picture of the esophagus and they cough and they inhale some of it and they aspirate it and they get an aspiration pneumonia because now the barium's sitting in their airways. It's not water soluble. It doesn't get absorbed very well. It takes time and it causes an infection. So, GI tract, bowel, or rectal or oral is going to be barium-based. IV or intra-arterial is going to be iodine-based. Okay? And we'll talk about those fun barium enemas later. Cavity space. So this is going to be a lot of MRI type stuff, some X-ray stuff. If I'm filling a cavity in an area, then I'm going to use another type of iodine-based contrast. Okay? So cystogram, so bladder study. Urethrogram, urethral study. Hysterosalpingogram, or HSG, for those who don't want to say big words, that is the study of the uterus and the fallopian tubes. Okay? Myelogram is a spine study, and then arthrogram is a study of like the labrums in the joints. Those are all iodine-based as well. those will get almost injected directly into those body parts, right? So the arthrogram is a needle right into the knee joint, into the shoulder joint, the hip joint, whatever that is. Fill it up with the contrast, go get your scan. The cystogram, the urethrogram, and the hysterosalpingogram, those are usually going to be done by a catheter and filled, and then pictures will be taken after the organ is filled, and we'll see some of those studies. Here are your risks for IV agents, right? Kidneys are your primary organ of concern, because when I inject stuff into the body, into the IV or the IA area, something has to filter it out. What is that? It's the kidneys, right? So, be concerned with patients who are dehydrated. In other words, tell them when you order these studies, hey, when you go get it, you need to hydrate, and hydrate well. A lot the day before, definitely the morning of, and then a lot the day after, to help your kidneys process this contrast. If they have underlying renal failure or insufficiency, or diabetes, because that kind of goes along with it, there's going to be a checkpoint lab-wise of when you can't give this contrast, because you will destroy their kidneys no matter how much they hydrate, and we'll talk about that. So you have got to be checking for renal sufficiency or diabetes prior to ordering these contrast studies. Asthma and lactic acidosis, also something to be concerned about. The asthma is really more, we're already concerned if they're doing those barium swallow studies, right? If they're going to aspirate the pneumonia. And if they have an allergic reaction to the iodine IV stuff, it can also trigger an asthma exasperation. So asthma is not one to where, like, if you have asthma, the patient can't have it. Okay? It's just something to be aware of. If they're on any medications that are considered nephrotoxic, right? You guys are done with farms, so you know all of that. Primarily the diabetic medications is really what I want you to focus in on for this course. If they're on diabetic medications, it doesn't mean you can't give them the study, but you need to ask them to discontinue them 2 days before the test. Don't take your diabetes medication for 48 hours prior to getting the study done. 2 days of no diabetes medication is not going to make a significant change in their diabetes, whether they're compliant or not. I promise you that, right? But those medications get processed through the kidneys. They're very hard on the kidneys. Diabetes is already hard on the kidneys. And now we're going to throw on a contrast on top of that. That's just too much, right? Too much. So make sure you're ordering a kidney renal function panel or kidney study before ordering this, so that way you know. Okay? I will say if they're, and this is clinic-wise, this isn't like academics. If they're under 40 and they're overall healthy, do you really need a renal function panel to order a contrast study if they're not diabetic? Probably not. But I would order one on everybody 40 and up, because you don't know if they have underlying kidney disease or not, because they just never got tested for it. Just from a protect your license, don't go to court standpoint, right? Yeah, and then the rest is just volume status. So just remember, dehydration, kidney failure, diabetes. These are things you need to know about before they get the contrast studies. Okay. I want you to focus on the serum creatinine levels. Really, the serum creatinine in general. So, out of all the lab tests that you learn in Clin Lab and the stuff that you order, what is the one that you want to double check academically? In clinic, it will be different, but academically, right? What is the one that you want to make sure is doing good prior to giving contrast? It's serum creatinine. Does anybody remember the normal range of serum creatinine? 0.5 to 1.2. Good. 0.5 to 1.2. So, if you have a patient that you're trying to evaluate, which of these lab values would make you concerned about using contrast, that range is probably really important. Right? You might have a BUN as a choice, but we sure as heck didn't talk about BUN. Even though that's a kidney function test, that's technically part of the panel, we didn't talk about it. Right? We did talk about creatinine, 0.5 to 1.2. So, and I'm not going to give you like, if that is a question, I haven't made the test yet, I don't know, but that has been a question on previous iterations, something like that. But I'm not going to give you like a 1.25 or a 1.3. It's going to be like a 1.8, right? It's going to be obviously elevated. There may even be other elevated labs that don't have anything to do with the kidneys, right? So, anyways, no serum creatinine, kidney disease dysfunction, volume depletion is the big one. Over 75, really seriously consider this on whether or not you really need it because they're old and we don't want to zap their organs too much. Pregnancy is just a straight up no-go, right? Do not give contrast to anybody who's pregnant. On top of that, you probably shouldn't be doing a CT on somebody who's pregnant either, because fetal cells are right up there with testes and ovaries and bone marrow when it comes to damage from radiation. So if they are pregnant, there are very few cases, and we will talk about them in block 2, where you should get a CT scan on a pregnant woman. Very few cases, but for the most part, if they're pregnant, no CT, no contrast. Regular X-ray is still okay, but no IV contrast. And keep this in mind too, right? What are we talking about here? Iodinated agents. Barium is not an iodinated agent. That is different. We are talking about the IV iodinated contrast. And then for your clinic stuff, recent use of contrast media or high volume, right? We talked about how taxing it is on the kidneys. If somebody like had a CT scan of contrast 3 days ago, like these recent ER people, right? And then they had one like a week ago, and then they had one like 4 days before that, they shouldn't have got that far. And they're on your doorstep, probably not a good idea to do another one, right? Just imagine the work the kidneys have been doing over and over and over and over again. But that's more in the kind of next level stuff. Serum creatinine, kidney issues, diabetes, pregnancy. Allergic reactions, okay? I don't need you to memorize the mild, the intermediate, or the severe allergic reaction. This is for you in clinic to understand the difference. I'm not gonna say, what is an intermediate allergic reaction to somebody who got contrast? That is not radiologically important, right? What is important is the no evidence for shellfish allergy cross-reactivity. But what is important is if you have a patient who has had symptoms after getting contrast, you tease out what those symptoms are. Because this allergic reaction will progress each time they get it. And it can be severe, and it can cause anaphylaxis, and it can cause death, right? So, what are the important things? Any of it, really, and it shows you the treatment. Again, this is for your clinic. What I need you to know is that if they've had a history of a prior allergic reaction to contrast, you do not give it again. Period, bottom line, end of discussion. As a PA, I would not be the one to decide to give it again. If you really, really think they need it, talk to your supervising physician, talk to the ER doc, talk to whoever you want to, like, hey, what do you think? But it's not worth it. I've seen as a rad tech before this going south very quickly because of contrast. What's that? I called the code and let the team do the thing at the time, right? They weren't in CPR status yet, so I didn't have to get involved. I just called the code, took them out of the machine. Anyways, what you're going to hear common, the most common thing, I don't want you to mistake for a reaction, is, well, yeah, last time I had it, I got really warm around all my body and I felt like I peed my pants. That's normal. The contrast is warm. It's hot, right? Otherwise, to make it less viscous so it goes in the veins better, it makes you feel warm from head to toe, and because of like the bladder and like all the vessels down in the pelvis, that just gets warmer. They don't actually pee their pants, it just feels like it. That's a normal thing. However, sneezing, hives, itching, that's not normal. Even if it was just, they gave me the contrast and I sneezed like 3 times and I was fine. Nope, not doing it. Yes? Yeah, so that's a good question, right? Nausea and vomiting, I would not marry to an allergic reaction. A lot of times they're told not to eat. It's, the contrast studies are done NPO, so that way it doesn't cause any vomiting because it can make people feel nauseous. So I would marry that to a normal reaction as long as there was none of the other things like the itching, the sneezing, the hives, that kind of stuff. Good question. So what are some other risks that we have when we give these things? So we already talked about screening and educate patients and all the risks of the comorbidities. Extravagant contrast, what does that mean? It leaked out. Whoever did the IV didn't do a good enough IV and it blew. And you can see it here in the x-ray. all this white, cloudy, the IV was in here, and I got contrast all in the soft tissue. That's contrast. Now the treatment for this is just warm compresses. They're gonna bruise, it's gonna be a little painful, right? But warm compresses, this is water soluble, right? This isn't the barrier, this will go away in a couple of days. But it's gonna be kind of painful. It doesn't mean they can't get another one again, but this is a potential risk. Usually what will end up happening is the radiology department will take care of them, they'll get them started on the warm compresses, and they'll come follow up with you in like 3 days or so just to make sure it's getting better and everything's okay. There's really nothing you really gotta worry about here, except for just watch for those rare instances that it doesn't clear up and causes an infection, which is very rare for extravasate contrast. A couple of different things on plain films or x-ray that we'll talk about. Fluoroscopy, CT, and mammo. So this machine here, has anybody ever seen one of these before? No? That's what they use in the OR. They'll use that in the OR or in some ortho clinics. So this is a C-arm. So it's the same thing as the x-ray machines. The difference is they can put a nice little sterile drape over it, they can rotate it, position it differently, and take live x-rays or live motion x-rays while in ortho or in surgery. So you will see some of this in your phase 2, especially if you're in ortho surgery, when they're doing like their hip replacements or knee replacements, injections into like the wrist. They won't use it for knee or shoulder, but little areas where you want to make sure you're getting in the right joint, they will use this machine. And so it's pretty cool. And then we'll talk about CT now in more detail. So here's fluoroscopy, right? So you can do one of two things. You can do snapshots, that are called spot films, which is just like a regular x-ray like we've been seeing, or you can hold the button down and do live stuff, like I was just saying, and actually watch them move the wrist, because then that way you can like position the wrist in a certain way, bend it, open up a joint, boom, needle in, steroid in, done, procedure finished, right? And so it's really beneficial there. That's why ortho is the top one for uses, ortho. They'll use it for cardiac, hepatobiliary. These are usually more in line with interventional radiology. So they'll use fluoro when they're going and putting like a stent in. And they'll trace it all the way up, like, oh, there's the blockage. Pull it out, stent in, and they do it under fluoroscopy. Here's what it looks like in the OR. There's the needle right here. So this is in the OR. This is more kind of in an ortho clinic. They're going to put the needle in and they're trying to inject, this is for an arthrogram, they're going to inject the contrast into that hip joint, into that label area. They're working on trying to aim the needle to inject it so it flows into that label area probably before an MRI to take a look at that hip labrum. So they'll use this kind of machine to do that. When it's in the OR, it's all sterilized and everything. Here's some pictures of the cardiac procedures just so you can see what they look like. This is where they can grab little clots on a little claw there from Toy Story. Claw. All right. And then drop the stent in, open things up. Ma'am?
Question. So with those movable like x-rays,
Uh-huh.
where are the, how do people protect themselves with those movable things?
Yeah, excellent question. So underneath the surgery there, what you can't see, is a lead apron. So the x-ray techs and the surgeons, a lot of times, if it's a study, if it's a surgery that's going to require quite a bit of radiation, you'll actually be wearing a lead apron underneath your surgical gown to protect you. And then for the patient, they'll have it, if it's the hip, they'll cover like the hip that they're not working on with it underneath their sterile drapes as well. Yeah. Here's some hepatobiliary pathology, right? Just kind of what it looks like, so you can look at the biliary tree. There's some better studies that we do to look at the gallbladder and the liver, which we'll talk about, but this is a fluoroscopy possible use. GI stuff, this is drinking the barium. So we got the esophagus coming down to the sphincter, down into the stomach, and you can see where it changes, and we'll go more this way too, how it's like super smooth, and then all of a sudden we got like the rugae and the striations of the stomach down here. So here's your esophageal sphincter going into your stomach. And here's just different pictures of catching the barium. This has that gap there because it's peristalsis, right? It just squeezed the contrast down here and opened back up, waiting for the next drop to come down. So really good way to highlight the esophagus, look at any abnormalities. We talked about the wrists. And fluoroscopy was just in the recent slides. Again, these are more for you. Lego Batman, because all the Lego movies are awesome. And if you don't think so, reevaluate your criteria for an awesome movie, and then go back and watch it again. Questions? Okay. Don't get hung up on one lecture per class period. There will be times we'll be ahead and I'll jump into the next one, or there'll be ones that are longer that take more than one, but it fits within the time frame, okay? Also, I encourage you as we're going through this to start writing down your questions that you have for clarification as you go through it. I will do a review session prior to the exam, but it's probably not like most test reviews you guys have seen, right? It's a Q&A. It's unadulterated, like 2 hours of my time, however much time you guys need, of you guys saying, I need further clarification on this, right? I come in, I have all the slideshows up and ready to go, so you can be like, slideshow 3, slide number 47, I'm really having a hard time understanding and distinguishing between these things, and then I'll pull it back up, we'll talk about it in more detail, answer any questions you have. So it basically becomes just a full-on, what don't you understand Q&A session, instead of me just up here going over the blue slides again that probably 70% of you don't need, right? It just depends on what you need. And that will be optional whenever we do schedule it, assuming that it's not in one of the required POI blocks, which usually it's not, it's usually an addition. So, but that's not for a few weeks yet, right? Any last alibis from me? Okay, I will see you.